Well, thank you all for attending, and I see that a few of you, survivor bias right here in the audience, Jay, they made it to the end, the most dedicated people. I see your certificate is printed, so if you really wanted, you could have left us a while back. Certificate's right there on the desk, but thank you all for staying to the end. I want to start by thanking Ramaswamy and Jay for putting this together. I think it was really an interesting day, and I mean, it's not the kind of thing I hear all the time in medical schools, so I think it's really, I thank you all for coming and being so attentive the whole day. I've also never seen an audience that was paying such close attention to what we were saying. I'm used to people on their laptops online shopping. I'm not used to this, so thank you all for doing that. We thought about what we were going to do, and we're going to record most of today and maybe put them out on YouTube and on podcasts. And I thought that for this last session, what might be nice is, of course, we have things we could talk about, but I think what might be nice is if you all steer the discussion, tell us what you want us to talk about. Both Jay and I have been doing and interested in evidence-based decision-making and medicine for quite some time. You got a surgeon, you got a medical doctor here. We've talked about a range of issues. Both of us have used a lot of general medicine and cardiology studies, but I'm happy to talk about things. Somebody's asking me in the break about case control studies. Somebody was asking me about hype. I'm happy to talk about more of that sort of social context of medicine or anything that's on your mind. So maybe we'll start by just taking some questions and go from there. Yeah.
I have a question about, observational studies and mostly established correlation. I was wondering if you see any benefit to correlate, studies that establish correlation outside of perhaps directing future research into causation. Is there anything you can use correlational studies for outside of saying, oh, there might be something there, now let's go do a causal experimental-based analysis of if there's actually a directional path?
Okay, it's a great question. I mean, yeah, so I guess let me just step back for a second and kind of frame this a different way. I mean, I think observational studies are really useful to answer lots of questions in life. For instance, if somebody's got lung cancer, how long do they live? That's a question someone has. Well, an observational study will tell you that. It'll tell you natural history. If somebody has lung cancer and they have a mutation in RAS, do they live longer or shorter than if they don't? So an observational study will tell you prognostic factors. It can tell you that prognosis is different. So observational studies are super useful. But what we keep coming back to is, as doctors, there's something that we do different than I think a lot of other fields, which is we don't just want to tell people what's going to happen to you or what to look for or what's linked to what. We want to tell you what you can do to be better off. Okay, a very specific type of claim. And that claim really requires causality. We need to know that what I'm telling you to do is actually going to make you better off. And that is very tricky. The easiest, most straightforward way, in my opinion, to get a causality and to get at the question of, well, should you, take vitamin D supplement every day? Should you, drink green tea? Should you, take a COVID booster this fall? Should you take FOLFIRINOX if you have pancreas cancer? The easiest way for most of those questions is to randomize people. I think it balances covariates, it balances the outcome distribution. In the absence of therapeutic effect, it really gets at the causal question of, should we be doing X, Y, or Z? If you don't have a randomized trial, you can do an observational study. Whether or not you get the truth is something that's been debated for a long time. And depending on how deep you want to go, there's a long history since 98, maybe all the way to the present, where people have taken observational studies and randomized trials on the exact same clinical question and asked, do they make the same inference about something we're doing? And there's a famous pair of paired papers, I think 2000, 2001. One author is John Concato, and the other is Ralph Horowitz. And these papers, and the other was Benson and Hartz, and John Concato and Ralph Horowitz. And these kind of papers made the claim that observational studies actually were pretty reliable. In the years since, people point out that it's not good enough to be mostly reliable. You got to be always reliable. A coin is 50% right. So it's got to be pretty close to 100%. And then we've tried all sorts of things: propensity score matching, inverse probability weighting, and most recently something called target trial. And the FDA commissioned something called Project RCT Duplicate, which was FDA's project where they commissioned Sebastian Schniedelweiss and colleagues from Harvard to take the target trial observational framework and apply it to 50 contemporary randomized controlled trials sent to the agency. And this is a paper in JAMA. and they find that there's some concordance. 70-80% of the time, they get the same therapeutic inference out of their observational study. Critics of it, like me, say that still ain't 100%. So being wrong 20% of the time is quite substantive when we're talking about very costly drugs. And then we have some unpublished research where we actually prove that it's cheaper to do the randomized study than the observational study. I can explain that more if you're interested. But your question is, back to your question. Your question is really about what is observational study. I think observational studies are so useful for so many questions we face. But for the question of what do I advise you to do, I'm very skeptical they're going to give me that answer. But they're going to tell me how long you're going to live. They're going to tell me things that are linked to your disease. They're going to tell me that people with HLA antigens are more likely to get ankylosing spondylitis. These are all observational findings, prognosis and those kinds of things, risk stratification. But in terms of telling you what to do, yeah.
So, just to add what was said, so well done observational studies can mimic the results of randomized clinical trials. That's what Horowitz and Concato looked at. So, poorly done RCTs don't really provide much information also. Correlation studies, when it's a strong correlation and it's a dose dependent and there are all those other Bradford Hill criteria, and in the absence of randomized trials or a randomized trial, then we will act on them as if they were causal studies. And that's the best that we have, and we live with that kind of uncertainty all the time.
Mm-hmm. Yeah, and I think that's the other thing that I think cannot be really important to state is that just because you're a randomized trial don't make you a good randomized trial. We've had so many examples today where we're showing you it's randomized, but we still don't trust the result because the control arm got sugar pill, because they didn't do MRI at baseline, because they didn't do PET CT at baseline, they didn't cross people over. So just being randomized doesn't mean it's good. Can a really well-done observational study get causal? I'm sure it can. And that's an area of active interest, yeah. What else you guys got? Yeah. Yeah.
My question is about nutritional research, actually, because there's a lot of things that may be unique, and for instance, we're correcting a deficiency, we're not treating a disease necessarily, and the fact that there's so much misinformation kind of in the lay press, and just also the fact that the vast majority of the studies are observational, just sort of by nature. So I'm curious, sort of, what are your thoughts in terms of the quality of most nutritional, especially micronutritional research out there? Do you think we should trust it? Is there a better way to conduct these studies?
Well, I like to drink my raw milk, so I don't want to get any studies of it. No. Nutritional research. Okay, so it's an interesting topic. I guess one thing I want to say is that in some ways, to me, it's a uniquely American obsession. When you go to Japan, when you go to Italy, you don't see the average person pouring through the paper to be like, should I increase my consumption of green tea? Should I eat more tomato sauce? They don't care in Italy, they don't care in India, they don't care in Japan. They know how to eat, they've been doing it for a long time, and they have a traditional food culture. But so I think one point to make is Americans, I think in particular, because we lack such a culture, we are engrossed by nutritional studies. The other thing I think is, like so many things in life, you would get so much more bang for your buck if you took people who are eating completely bad junk food and just try to move them towards eating more stuff they're cooking at home and more healthy choices. But the people who are obsessed with the nutritional epidemiology tend to be people who are already wealthy, affluent, readers of the New York Times. They read the well column. They only eat fish once a week. They don't eat too much tuna. They're worried about mercury. And they want to know, should they eat an extra serving of blueberries? So it's a really unique question. What I would say is that, to me, the literature is almost hopeless. The observational literature is hopelessly confounded. There are hundreds and thousands, maybe millions of analytic plans. If you take a dart, this is a famous study by John Ioannidis, he opened the Boston cookbook and he took a dart and they threw the dart in the cookbook 50 different times. And for 50 different ingredients they looked up on PubMed, does it lower the risk of cancer or increase the risk? For 40, there's a PubMed study. For everyone, there's a PubMed study if you're a little bit permissive. Instead of looking at vanilla, if you accept vanillin, the flavoring of vanilla, there's a study. And they found that for most of the studies, you can find a study that shows it lowers the risk of cancer or increases the risk of cancer. In other words, people have run so many observational studies and gotten all the answers you could possibly get. So what do we know about nutrition? I don't think there's a lot we can say with certainty, especially micronutrient stuff. You talked about deficiencies, but things like rickets and scurvy are rare and real. But most people are talking about, should I take vitamin D because I'm at 14 international units or something? Like, should I take vitamin D or not? And we know very little about it. The last thing I'd say is there was a really interesting study called Look Ahead. It was a $150 million NHLBI study. They took overweight type 2 diabetics. They weighed like 96 kilograms. They have type 2 diabetes. They're like 64 years old. And they randomized them to intensive diet and exercise for 13 years, okay? The primary endpoint of the study was cardiovascular events. The secondary endpoints were waist circumference, weight, how you feel. The published look, it's called Look Ahead, it's a New England Journal. Waist circumference is smaller. Weight is lower in the people who did the diet and exercise. Everything is better, except the study was halted for futility at 13 years because there was no difference in MI, stroke, or cardiovascular events, even though they lost more weight. So I think, nutrition is somewhat of a mystery. And the last thing I'd say, people are very curious about alcohol. Is it good for you, bad for you, good for you, bad for you? 1 beer a day, glass of red wine. We've been through this long enough. They've been bouncing around. Maybe about 15 years ago, they were going to run a randomized control trial, NIH-sponsored, to answer the question, randomizing people to be encouraged to do a little drinking or no daily drinking, okay? Observational data is problematic because people who are teetotalers, people who don't drink at all, there's two types of people. There are people who just don't drink, and the people who've got a drinking problem and they don't drink, There's two groups of people in teetotalers. And, it's also confounded by socioeconomics and all these things. A randomized study would be great. But the study was halted because the funder turned out to be Jose Cuervo. And so, so I support a randomized study of alcohol consumption. I think you can randomize people to be encouraged to drink and randomize them to be encouraged not to drink. You can't randomize them to actually drink or actually not drink. You randomize them to the advice. That's the study. It's a study of what you advise people. And then you follow them for 10 years and look at not just breast cancer or colon cancer, look at everything. Well-being. Depression, rates of depression, suicidality, how many people stayed married or got divorced, and cardiovascular events. I think it would be a really interesting study to kind of answer this, and it should be done by NIH. Your thoughts on nutrition?
I completely agree. The nutritional epidemiology research field is a mess, and John Ioannidis talked about how big of a mess it is. We talk about it in one of our classes in the med school curriculum. And do you have to look any further than the food pyramid and how we got that wrong for how many years? And fats and proteins and sugars and stuff. So I don't really trust much of it at all. I'm very skeptical. But I also respect it's hard to do.
But the real question is, what does Jay eat? That's what I want to know.
To do what?
No, we're both such skeptics of the literature, but at the end of the day, you got to eat something. So how do you decide what to eat in your life?
It tastes good. Seriously. Dr. Piccarello, do you like to eat blueberries because, it's good for brain metabolism? Absolutely. I eat them because they taste good. And do I eat strawberry? Because I taste good. And I just in moderation and just be reasonable. I have no patience for all this other stuff.
I'm actually really close to you.
Yeah.
I'm drinking a Coke now, but I don't buy it. I don't drink in my house. But one after talking all day.
Special day today.
A special day, right? Yeah, right. And then
I don't have it at home.
Generally, eat in moderation. Try to cook more food at home and that kind of stuff. And my family's from India, so of course, my mom knows what I'm supposed to eat, and she tells me. So there's that. All right. Yes.
What are your thoughts about the balancing act? For example, you talked a little bit about the vision trial, and in your podcast talk about the vision versus therapy trials. The vision trial has its drawbacks. But the other thing is the FDA, the US population didn't have access to radiation PSMA 617 until very recently. And a lot of patients for the last 10 years, they used to travel to Europe just to get that kind of treatment. So one of the arguments of, the funders was that we wanted to have a broader base of trial, a broader base of population to kind of get this drug approved in the US. So I'm guessing, as clinicians, how do we see this a sort of balancing act of, designing a perfect trial versus trying to have that thing which you think has an effect, trying to have that available for your patients?
Yeah, so this is something that Vincent Rajkumar says, which is the reason we run our trial with a bad control arm is it gets a result faster, which means that we have access to the drug faster. My counter argument to that is, having access to a drug doesn't always mean you know how to use it wisely. And running the study right tells you how to use it wisely. There was famously the drug gemtuzumab uzigamycin, which was FDA approved at 9 milligrams per meter squared based on uncontrolled data that it shrunk tumor. And then it was withdrawn from market when 9 milligrams per meter squared was found to kill people and cause VOD, vaso-occlusive disease. But it was brought back onto the market at 3 milligrams per meter squared after a bunch of randomized studies showed that that dose was beneficial. It's like that Paracelsus quote, "It's the dose that maketh the poison." You know, so if you don't know the right dose, the right person, the right timing of when to give a drug, it might not just be an option, it might be deleterious. So for instance, lutetium PSMA might have a survival benefit. Like, first of all, they could have done it a different way. They could have just done lutetium PSMA versus investigator choice for someone who's progressed on docetaxel, cabazitaxel, you know, and so it'll be like maybe lutetium PSMA versus mitoxantrone or, you know, whatever. They progressed on everything. That would have been a very quick study for OS. They want the bigger population, you know, and lutetium in other countries is much cheaper because each hospital makes the radioisotope. And in our country, lutetium is through the roof. So like in, Mike Hoffman says that in Australia, like they make it in their hospital for like pennies on the dollar. So I think that's a different thing. So to me though, like honestly, gun to my head, I don't know when the best time to use lutetium. Should I use it before docetaxel? Should I use it before cabazitaxel? I personally think probably Abi, Enza, then you go docetaxel, then you go cabazi, and then lutetium, but I don't know that for sure. So I do think I would rather live in a world with the right studies than studies that lead to more approvals. That's my bias. You want to talk about it?
Nope. But I wanted to ask you, you've been around you're around the country all the time, and you were previously at Oregon before UCSF. What's your perspective on the degree of teaching of critical appraisal skills, and how are we doing at U.S. medical schools, and can we do better?
I'm always impressed, Jay, when I come here because you're doing a good job. I was like,
That's not what, I'm not looking for a plug. But how can we do better?
How can we do better? Let me say my experience. I would say at University of Chicago, where I trained, and I was just telling people, this was 18 years ago I went to med school, so 2005 to 9. I would say the whole first year, my brain atrophied, and it was misery. It was rote memorization, 40 hours a week in class, and I didn't learn anything about what you just taught them. I didn't learn anything about epidemiology or statistics. I didn't learn anything about critical appraisal. I just learned Krebs cycle, you know, the subunits of the ribosome, and you know, and supposedly I've given so many antibiotics, and for the life of me, I could not tell you what subunit of the ribosome it inhibits. But back then I knew, you know? I knew. So I learned all that stuff for one whole year. Then the whole second year, the first half of the second year, they wasted another 6 months. The second half of the second year, they started to teach like clinical medicine. You know, if you hear an S3, what's the likelihood ratio, sort of some of the kind of basic stuff. And then it was really in my clerkship when I met Adam Sifu, with whom I ended up writing a book. We became friends. I was a clerkship director. He was a really good evidence-based medicine teacher. He had trained at the Brigham. And the moment I realized he was a good teacher, which is the real advice I give students, the moment you find a faculty member you like, you grab their arm and you hold on tight. Because somebody who you like is going to teach you a lot more than somebody you don't like or respect.
The specific project.
Or a specific project, yeah. It's somebody you like. And so I grabbed onto Adam and I learned all I could from him. And then I went to residency Northwestern. Again, critical appraisal was an afterthought. I mean, it was only a few faculty members who cared a lot about it and taught it, but most people just kind of went with the flow. And then for me, a fellow, I worked with Tito Fojo, who to me is sort of one of the greatest critical appraising guys. You published the John Conley lecture, 2012, at JAMA Otolaryngology by Fojo, very highly cited paper.
Yeah.
He was like a really thoughtful person. So along the way, I've learned from people. My view of medical education, is this being recorded? I guess it is, but I would say I think it's bad. I mean, it's a problem. I view many problems in it, and I can't speak to WashU, but I can speak to places I've worked. One of the problems is that who decides who teaches the course? Okay, if you're really an all-star, successful, R01 funded researcher, everybody will tell you, you don't teach that med school course. You're too successful. What do you want to be teaching these students for? It's going to drag your career down. You should be out there giving lectures and grand rounds and talks. So it's really some of the stars, the great speakers, are drawn out, which I think is a problem. Then there's an extreme politics over, in my experience, of who gets to teach these classes. And once someone sinks their tentacles and they're the first year medical school epidemiology director, They sink their tentacles into it. They hold that position for 15 and 20 years, even if they're the worst public speaker I've ever seen in my life. And now they just make videos of them delivering bad lectures and then make the students watch a double speed video. To me, I'm like, what's the point of even having a UCSF epidemiology class if we make them watch we can just have a national video, the best video from Harvard or whoever wins, the best video, make every med student watch it. If we're all gonna watch videos at home, if that's gonna be education, then just pick the best video. I don't wanna watch some random person who happens to live in my city. So I think that's a problem. And then I think that we're stuck with that stupid step one. Even whether we like it or not, we're all building our curriculum around step one. And step one is a curse. It forces all the schools to have a canonical curriculum, and schools cannot innovate curricula. If you deleted step one, which it should be deleted, not just pass-fail, which is a stupid suggestion, if you deleted it and you let schools say, teach them whatever you want, or then some schools might try more. They might put you in charge, in a school for a year, and somebody else might put something else in charge, and we'll get some sort of laboratories of experiment. And then the final thing I think about it is that there are lots of people who are really good at doing research, but they're not good at explaining it. I think isn't it a different skill set? It's I know people are really great analysts, but they have difficulty explaining it. I personally believe that examples, so I try to give you a lot of examples. I also think recent examples, try not to use some of the older, I sometimes start to feel my age. I'm using older examples, I want to swap them out. I think that helps. And then the final thing is, nothing you do will get everyone's attention, but you'll at least get some people. And as long as you start to get a few more, every year it grows, I think.
Excellent.
Well, what do you think? You've been doing it for a while. What's your
that all
answer?
makes sense. I think you have to grab the students' attention and make them understand why it's important. Basically, as I've told many of you, that's why I got asked to teach the class, because the biostatisticians who were teaching it before me, apparently, according to the students, weren't making it very clinically relevant. And so they were learning about central limit theorem and probability, but not really how it relates to taking care of patient. And for me, that's what has made this all so valuable as a medical student and a resident myself, asking, why do we do what we do and how do we know it works? And there's a whole science behind that. As you like to say, the basic science of clinical medicine is clinical epidemiology.
All your slides are really good. It's very simple, getting at the core message, and your examples are clinical examples, real papers that really, so I think that's really what makes it good. So I think it's an exemplary, talks you gave today, yeah. What else? Yes?
So my question is a little bit more broad, I guess. For your average community medicine doctor who maybe isn't so ingrained in the research as it is in academic centers, I guess as we've seen today, you can't really trust the FDA or all these high-powered research journals. What would be your advice to them? How are they supposed to navigate this process? Are they supposed to be as skeptical as you guys are about articles?
Yeah. Okay. You want to go first? Okay. I think it's a really good question. I think that some of the smartest people I know are community doctors. I think the idea that the academic doctor is on some pedestal and the community doctor is doing, I think that's got to go away a little bit. Some of the reasons why people are community doctors is a smart person wants to be paid twice as much to do the same amount of work. So that's a good reason to go into community practice because the pay is better. But I do think, to your question, which is that, and I think a lot of academic doctors uncritically accept what people say. I think the majority of people I interact with, even my colleagues who I respect a great deal, they say things to me that if I really said, why are you saying that? Where did that come from? They cannot get to, they're like, well, honestly, I just heard it from somebody. They actually don't know the root of what they're saying. And I think that's a problem that people have, is that they say things they just heard. But I do think, in 2024, whether we like it or not, if you want to go and practice medicine and do the best job possible, you gotta put some work in. It isn't always learning field. Something new is gonna come in your field and you're gonna need to read about it and learn about it. And I don't think you can trust, the journal or the conference. I think these conferences are loaded with hype. Luckily, there are increasingly critical podcasts in so many fields. I've done one in oncology for a while, but there are other fields I see have one. Rheumatology has one. There are more of those kinds of things. But I think you do have to learn the skill set, and you will need it in your practice, no matter what it is, I think.
I think community physicians, maybe more than academic physicians, are really keen to their patient outcomes because they are seeing so much more volume. They're directly related. We have residents, fellows between us necessarily. Maybe they're a little bit more skeptical. They kind of don't really believe the literature because it just doesn't ring true or make sense to them. And they're not wrong. 80% of published research findings are false. So much of the research being published may not have clinical applicability, so they just kind of turn it off and they go with what they learned. And we talk about that as being pejorative. They haven't learned anything since residency. On the other hand, they've learned what works and what doesn't work, and I think they're very, like most good physicians, they recognize patterns, they're good observers, and they learn quickly and they modify. Why? Because they're butts on the firing line with regards to their patient outcomes, not the least of which is litigation concerns. So I do think they're very, very keen to how their patient outcomes are modified by what they do.
And the more you do it, you get faster and faster. I mean, if you gave me a paper in oncology right now and said, present that to this group in 15 minutes, I think I probably could do it because I've been doing it for so many years. But if you asked me when I was a fellow, I think I would cry. I wouldn't be able to do it. It just comes with practice. Yeah.
Vinny, what does that learning curve look like? A student asked me that during one of the breaks. At what point did you feel comfortable to kind of move through a paper quickly? When did you have it? Was it a threshold aha moment and now I'm set, or was it just sort of a linear thing over time?
I think it's still linear. I feel like every year, I think the best part about this job is every year I learn things I didn't know before. And like every once in a while, I've been reading something for like years, and then finally I'm like, I always see that in this paper. I don't feel like I fully understand it. I don't think I could explain it. For me, like the litmus test is if I went to a dinner party and I sat next to someone who wasn't in medicine, could I explain it to them? And if I can't do that, then maybe I don't understand it. And so then I'll go back and read and try to learn about it. And so I think I would say, maybe it'll change someday in the future. But I think I feel the last 5 years I've learned as much as I learned in the first 5 years.
Okay.
I feel like it's continually learning, and there's a lot more to know because there's a lot of stuff I don't know, and I want to learn that. I always want, every once in a while, some fellow comes on service with me, and we're seeing prostate cancer, and I'm like, let me give you a little lecture on prostate cancer. I say, oh, no, I'm actually going into CML. I don't need to know about this. And I'm like, steam comes out my ears. And I'm like, well, I like to know about things, even if I don't do it, I just like to know things.
Yeah. So you'd agree teaching something is a good way to learn?
Oh, the best way.
Yeah.
If you can explain it to someone in your field, a friend, isn't that it shows you know, and if you can explain it to somebody and feel their questions, whatever those questions are, I think that means you really know it, I think. Yes?
I have a question. As Dr. Piccarello said, I'm a librarian, and my job is to get evidence-based literature in front of people. I push it, I go up to people, I offer my services, and if so much of this is skewed, 80% of it's false, especially because people do ask me for higher evidence levels, and I'll automatically, if someone can say, oh, I just want randomized control trials, I give that to them. Is that harming, or is there should I give them like a, notification, like warning at the bottom of
Disclaimer?
Yeah, disclaimer to what we're giving? It's the foundation of evidence-based practice.
Well, I think this workshop is sort of the disclaimer for our students and trainees, but for the public, oh my gosh, no, they have such faith in what's published and what's presented on the evening news, and it's very challenging, I think.
I would say that, a lot of my priors in medicine have been the same for 20 years now, which is that some of what we do is exceptional. A lot of what we do just doesn't do what we think it does, and some of what we do is marginal. That's always been my prior. And I've always sort of been critical of medicine, but some things you apply it to, you get more heat than other things. I was telling somebody 10 years ago when you talk about cancer trials and you said that the benefits were marginal, it was very difficult to say that. 15 years ago for cancer screening, when Gil Welch was doing his stuff, he got so much heat. Now there are still some, I think, pandemic-related topics that I still get heat for, but that's dissipating. I think that it's often people have strong. When people look at decisions with moralistic terms rather than intellectual terms, when they feel like there's a good and a bad, it's very difficult to be a critical appraiser. Sometimes in oncology, somebody says, it's bad if you don't give osimertinib, adjuvant, And the moment you start to have moral dimension to it, it's harder to look objectively at that study. Does it prove anything? What does it prove? And so I try very hard not to somebody once told me that if you debunk this surgery, you're going to debunk a big chunk of my livelihood. And I'm like, well, you know, if I'm giving there's no chemotherapy regimen that I have any allegiance to. You can debunk anything I'm giving, and I'll be happy to admit I was wrong all those years. So like, I want to be proven wrong. So I think don't fall in love with your therapies is another sort of advice I give. Yes?
The question relates to clinical equipoise when we decide to run studies. We talked today about Nutritional and that we only really have any idea if it works at full dose. You mentioned Paxlovid, where we don't really know if it works in a vaccinated population. And then there were all studies that we didn't run during the pandemic, whether it be on masking or different vaccination regimens, one shots, spacing out shots, all those kind of things. And so it seems that there are all these studies that we're not running because ostensibly we're saying that there's not equipoise to run the study. And so, but it seems like we probably should. So is it just a humility thing and we have to realize we know less and should run more studies, or are there some systemic changes that we should make to encourage more of these studies? Like, interest is not okay if you only prove it at max dose, you have to show that it works at all the other doses you want.
Yeah. It's a great question. Okay, I'll give a little bit of an answer. One is, I think we should think about what does equipoise mean? Okay, so in one conception of medical ethics, there's another conception, but in one conception of medical ethics, you can only run a randomized controlled trial when you have equipoise, which means genuine uncertainty about which is better. Okay, the original conception of equipoise, originally offered, was that each doctor who enrolled on a study had to they themselves be in equipoise. I have to genuinely be unsure if clofibroate is better than placebo for me to enroll my patient on the study. Well, then somebody came along and realized, well, that's a very paralyzing definition of equipoise. That means that if she likes osimertinib, she won't enroll, but if he likes osimertinib, he will enroll on Laura, for instance, you know? It's very paralyzing. So then came the Friedman 1973 definition of equipoise, where he said equipoise does not exist at an individual level, it exists in a community of doctors. Among all us docs, we don't know the answer, so we can randomize. And so even if she feels strongly it works, and he feels strongly it doesn't, they both in good conscience can put a patient on the study because their field is in equipoise, okay? This is one conception of ethics, that in order to run a randomized study, the field has to be in equipoise. I would argue that Polo, honest people would say they're not in equipoise between stopping all therapy because you wouldn't stop all therapy, and that's why it's a delinquent control arm. There's an entirely different conception of medical ethics offered by Franklin Miller and Steve Joffe, where they say equipoise is neither necessary nor sufficient for the ethical conduct of studies. The field doesn't even have to be in equipoise. We can randomize any question where the value of the information we obtain is better than the harm to the people who participate in the study. If we're going to learn something that's going to save 1,000 lives and make people better off, we can do that study. Now, one place that played a role is challenge trials. What is challenge trials? In the pandemic, in June of 2020, you're facing a winter where we're going to get, 150,000 people dead, and you need a vaccine fast. And they're doing a randomized controlled trial of randomizing people to the Pfizer-BioNTech vaccine 20,000 or 20,000 people getting placebo. And they have to wait for people to be exposed to COVID in the course of their regular duties before they get the result of this study. And that result's going to take a few months. There were some people who said, we don't need to be in equipoise and do this study. Here's what we can do. We can bring in 100 healthy volunteers, 18-year-old students, pay them money, $20,000 a pop, and make them sit in a house. 50 of them get vaccine, 50 don't, and then the sprinkler system comes on and sprays COVID-19. You'll get the answer. This is the proposal. This is called a challenge trial. You will get the answer in 4 days. And how many lives might you save, okay? Now, I mentioned this to say I'm not condoning challenge. I actually think challenge trials have a role, and I published on it. But the point of this is that there is a view of ethics that says that trial is not only ethically permissible, it's ethically obligatory, because you will save 150,000 people. None of those kids are going to get seriously ill, realistically. We know that. We knew that at the time. And a few of them are going to get the sniffles, and some of them might get hospitalized, but we could probably save the one person that's going to happen to. But the information we get will save 150,000 people, pregnant women, mothers, all these things. So they're saying it's ethically mandatory to do that. So that's the Franklin Miller conception. Okay, back to your thing. I think when people say, I don't think you even have to go that far. You don't even need a challenge trial. There are lots of questions we didn't do because people said there wasn't equipoise. Very famously, Rochelle Walensky, the CDC director, went in front of Congress, and she was asked by Congress and said, why did you, as CDC director, never randomly assign children between the ages of 2 and 5 to wear a mask or no mask to show it works in this very young age group where it looks like they chew it a lot, like looks like they're not wearing it correctly. And Rochelle Walensky said there's no equipoise for me to have done that study because it would have been unethical to not do that to kids. But what undermined her claim was the European CDC specifically said, don't do that. Spain never did it, France never did it, Sweden never did it. So globally, there was a global equipoise on that question. So I think, as a matter of fact, she was incorrect. There was equipoise for that question. So that's a long answer to your question. But I think it's an important backdrop, which is that not everyone thinks you even need equipoise. And then I think equipoise exists much more than people think. The more you look at the history of medicine, you see how we got things wrong, the more you will have equipoise. I've looked at so many reversals, we wrote a whole book on it. There's very little that I feel very confident on. If you told me, Prasad, do you like ABVD for Hodgkin's? I said, I love ABVD for Hodgkin's. It's curative. We cure so many people. If you say, are you 100% sure that that everybody you've ever given ABVD to needed ABVD? I said, I'm a little, I have a lot more doubt than I did 10 years ago. And the more I practice, the more I personally have doubt, and the more I wish I had more studies. Because I've learned that studies can be wrong and exaggerated, and subsequent studies can have different results, and they keep running the study and the effect size gets smaller. I've learned all these things, and so I'd say I welcome more information. And so is that kind of an answer to your question?
Mm-hmm. I guess I just wonder, is the solution to Dr. Walensky saying, no, we don't have equipoise to this question, saying we need a regime change and someone else needs to come in who realizes we need to answer this question? Or is there something in our system where we're encouraging these things further? So just on the interest point, right? We allow as an endpoint the approved max dose, therefore we give it to everybody, even though only 2% of people are getting max dose. We should run this study. Yeah. I don't know of anyone who's trying to.
No, great point. Okay, so I have two answers to that question. One answer is that, and I've written, that if public health uses the force of government to enforce some policy mandate, the brute force of government, I've written, they should have a period of time, 6 months, 8 months, where they get to do that. But if they haven't run a randomized study showing benefit, those restrictions must fall. They failed to meet their end of the bargain, proving that it works. But for the next point I'd make is, the current federal budget on healthcare is $1 trillion between direct Medicare, Medicaid outlays, and subsidies we place for employer-based insurance. We're probably $1.2 trillion. The entire federal budget on running randomized controlled trials is probably something between $3 and $9 billion. It's a subset of NIH budget. We spend, 1/1000th, maybe 2/1000ths of the money testing what we're just running the tab on. No company would ever do that. They would say, listen, if there's so many things in healthcare that don't work, and we're spending $1,200 million a year on this, we should spend 5% of the budget just to randomize people. So if we can find one, Tamiflu, one Vioxx, we're gonna save 20 billion here, 10 billion there. If Entresto doesn't work, we're gonna save 40 billion life cycle. It's silly not to do this study from the standpoint of the payer. And so I think the solution is, when you have the system align, to have a new agency that's tasked with running randomized controlled trials in an effort to find what doesn't work. Probably $400 billion in annual healthcare spending is absolutely uncertain what we're doing, and that should be systematically tested. And Entresto would be a great example. First thing I do, test Entresto, It's a great question. Yeah.
When do you think it's appropriate in oncology to do blinded randomized controlled trials versus open label?
That's a good question. So I, as a general rule, think that blinding plays more of a role if the endpoint is subjective than objective. So for instance, if my knee is achy and the orthopedist says, I'm gonna take a scope in there and debride the cartilage, I would say that could also be a placebo effect. So I would be really okay with a blinded study of they do the knee debridement or sham procedure. If the endpoint is something like my elbow aches and I'm randomizing to taking a new pain medicine or not, I think placebo control will have we'll get rid of that because the thing is achy. If the endpoint is something like overall mortality, then blinding plays less of a role, but it still might play a role because if you know they did or didn't get something, you might change your downstream behavior. You might be more or less likely to give them second line something else. You might be more or less likely to send them to radiation. All sorts of other things change. So in my mind, one of the virtues of blinding is so that it sort of gets some comparability between all the other treatments around a patient. In oncology, the nice thing is it's easy to blind. Pills can be made in sugar pill form, and IV medications can be made dummy bags. You can do a thing called double dummy, where if one arm gets a pill and the other arm gets an IV, both arms get the opposite placebo, a pill placebo and an IV placebo, double dummy. And I think we have shown that when you don't blind, you get more dropout from control arms. Let me say that again, and then you tell me why. If you run a randomized study of new sexy cancer drug versus old cancer drug, versus new sexy cancer drug versus blinded placebo, more people drop out of the control arm if it's old drug and less people drop out if it's blinded. Why is that? You know the answer. Correct, disappointment. So and the more they drop out, the more you have an unrandomized study. They're not dropping out at random, people are connected and affluent, they're the ones dropping out. So blinding also preserves randomization in many ways, so that's another reason I like it. Any thoughts?
No, I totally agree. Mm-hmm.
Yes.
Could you give some examples of what you think are really well done RCTs, specifically ones that had a lot of challenges or biases to face and that controlled for those effectively?
And did it have to be positive or negative?
Doesn't matter.
Okay. Well, in 1993, there was a really famous study we have a lymphoma doctor here, Rick Fisher et al. This is a randomized controlled trial of CHOP versus promacytobam versus M-Baycod and a fourth multi-drug chemotherapy regimen. And the reason this was such a great study was that it was a 4-arm, 1,200-person randomized controlled trial of people with lymphoma, 4 different chemotherapy, an old sort of simple chemotherapy called CHOP, 4 drugs, and then 3 more kitchen sink approaches, more drugs. In multiple uncontrolled phase 2 studies and in observational literature, the newer regimens outperformed the old regimen, and not just a little, but substantively, 20, 30 points better. But when they randomized them, it was like a 100% tie, just complete tie, That's one example. I'll give you another example. In July of 2020, in the initial COVID-19 waves in the United Kingdom, they created a consortium called Recovery, which was a randomized control trial consortium. And they ended up studying many, many drugs that might be effective in COVID. And one was dexamethasone. They randomized 6,000 people who were hospitalized with COVID-19 to get dexamethasone or no dexamethasone. And they looked at mortality as the endpoint. But they did something even more clever. They had a pre-specified statistical interaction test. In other words, they said, among the people coming into the hospital with COVID, some people might just have difficulty breathing, but they don't require oxygen. Some people might require oxygen, and some people might need to be mechanically ventilated. What if dexamethasone works in one of these groups, but not the other 2? What if it only works for some of those people? So they pre-specified in the statistical plan testing to see if it works in some group and not other group, like on oxygen but not no oxygen, and they cranked up the power so they had power to detect what we call an effect modifier, whether oxygen modifies the benefit of dexamethasone. And in fact, in July, they issued a press release. This was Martin Landry. Martin Landry from Oxford puts the press release. It says, dexamethasone reduces mortality in COVID-19, but only if you're on the vent or if you require oxygen. And if you don't, it may even increase mortality. So give dexamethasone tomorrow if they're on the vent or have oxygen needs, but don't give it if they don't. And that was a hugely life-saving result. Huge randomized controlled trial, well done, pre-specified statistical plan, interaction coefficient, run by the best group in the UK, really, really solid science. And to your point, if the US was running correctly, we would have done the same thing, but bigger and better, but we failed miserably. We didn't do any Recovery has tested so many things. They have now 12 different trials they've got on this platform. We didn't do anything like that. And so they just crushed us, and UK crushed us on that, yeah. Those are just a couple examples, but there are lots of good examples, yeah.
Well, with that, should we end?
Okay.
Great. Well, with that, we'll end today's Midwest Critical Appraisal Workshop, our first ever. Thank you so much for your attendance. There are certificates outside on the table, alphabetical. And we just welcome your suggestions. We will be sending out a workshop evaluation. Please, again, give us your thoughts and suggestions. You have the box folder available for you. And thank you so much, Vinay, for coming.
Thank you.